I want to acknowledge our university and community supporters, University of Iowa's international programs and University of Iowa honors program. They contribute vital time, talent, logistics to this organization. I also thank the Stanley UI Foundation support organization for their financial support, and today's special financial sponsors, Joyce and Dick Somerville and Jane McCune. Our programs are made possible by the generosity of these sponsors. And I'd like to introduce Rebecca Arnold. Rebecca is Senior Program Officer, as I've said, at Johns Hopkins Center for Communications Programs. She's been in Dhaka, Bangladesh since 2012. She's currently Director of BKMI, which is a USAID-funded project that provides capacity strengthening and technical assistance to the Ministry of Health and Family Welfare in Bangladesh. She previously worked in Tanzania, served as a community health volunteer for the Peace Corps, and she's a native of Rock Island, has an MPH in Community and Behavioral Health from the University of Iowa College of Public Health. She has a BA from Northwestern University, and she's in Iowa City to receive the University of Iowa's International Impact Award. So please join me in welcoming Rebecca.
I have to lean in. Thank you, Christopher, for the very kind introduction, and good afternoon, everyone. I'm thrilled to be here, happy to be in Iowa City, happy to be in the United States during autumn. I kind of forgot about it. We tend to come home at Christmas, and during the summer I have a school-aged child, and so it's been a few years since I've seen autumn, and I'm enjoying it tremendously. I'm looking at the title of this presentation here, and I'm a little bit bored. But I'll do my best to liven it up as much as I can. And so I'll talk a little bit about Bangladesh. We'll talk about public health in Bangladesh, and then about the work that I do right now. Maybe I'll back up a little bit. So I was actually, just to kind of bring us to where I am in my career. So I started out as an undergraduate with not a clue of what I wanted to do, so I have a very strong liberal arts background. I actually studied American culture as an undergraduate, and here I am as a global public health person now. But the common thing is that it was an anthropology-based and multidisciplinary major at Northwestern, and you learn how to study a culture, whether it's your own or somebody else's, and that's a good skill to have when you're working in global public health. So I had a couple of opportunities as an undergraduate to work overseas, and I got the bug. I knew I wanted to go back and live overseas again, didn't know where, didn't know how, or what I would do to get myself there. But I came back to Chicago, worked for 5 years in a publishing industry, and eventually hit a point where I need to go. I need to go to another country, I need to add some value to the world, and I joined the Peace Corps. They sent me to Madagascar, so I kind of hit the jackpot. That was a great place to be. As a volunteer living in a very isolated, poor, rural area. A lot of cows, not much rain, but I loved it. And before I went there, and before they assigned me to be a community health educator, I had no idea what public health was, not a clue. So I went there and I thought this would be something interesting and fun to do for a couple of years, feel like I'm making a difference, and didn't have any idea that I actually had stumbled upon my passion and what I really, really love. And so it's turned into a career path for me, but I never knew that was going to happen. After that, I went to Tanzania for nearly 4 years. I worked for a national multimedia entertainment education initiative targeting young people about lifestyles, healthy lifestyles, and HIV prevention. But you can't only talk about HIV and expect young people to listen. So we packaged our media products, magazines, television show, website, other printed materials in the context of youth lifestyles. So music and popular culture and fashion and relationships and education and job opportunities and the full range of things that young people are interested in. And once you start talking in a way that they can relate to, you use their language, you use images that reflect them, now you can start to talk about HIV and how to stay healthy. So that was about 4 years in Tanzania. I came back to the Midwest for about 6 years. It took me 4 years to get my MPH, one class at a time while I was working full-time, and also doing some consulting. Needed to be in the Midwest to be near family for a few years, but wanted to stay connected to global health, so worked as a consultant for organizations like CARE and Measure DHS, FHI 360, to stay connected and because I knew I'd always go back. Eventually I would go back. And in 2012, Johns Hopkins Center for Communication Programs had an opening for a health advisor in Bangladesh, and they hired me, and off I went. So that brings me to my current position. But first, let me just share a little bit about Bangladesh. For some of you are familiar. I'm sure I'm not telling you anything new, but here it is, right next to India, formerly East Pakistan, which I was surprised to learn about. And the other interesting thing here is that 90% of the border is with India. Myanmar, there's just a tiny little speck down here, but there's parts of India that are east of Bangladesh, which is an interesting part of India. But there they are. And then when you look at the map of Bangladesh itself, it's very clear that it's dominated by water. These big rivers coming in from India. Down here, it's this very large mangrove forest. This is where the Bengal tigers live. Down here. Over on the southeastern side, you've got some ethnic minorities living in what they call the hill tracts, which are very culturally and ethnically different from the majority of people in Bangladesh, and it's a constant challenge to make sure they're included in public health efforts. So Bangladesh, just broadly speaking, faces many geographic challenges. First of all, are these big rivers controlled by India, so Bangladesh is at the mercy of India for water coming through. Very prone to flooding. I'm sure you've heard about this in the news. It pops up every few years, the severe flooding. Just because of where they're located. They're vulnerable to tropical storms. They're at sea level. So, slight changes in the ocean levels, just tiny little changes, and suddenly the groundwater is contaminated. So when the water becomes more saline, crops that could grow formerly are not able to grow anymore. People are facing health challenges that just by exposure to the salt water coming from the ocean. So it's not that they're drinking salt water, but they're washing their dishes, they're washing their food, they're washing their bodies, and their hypertension, other cardiac diseases, diabetes, eclampsia in women, which can be fatal. So the additional salt that's making their way into the bodies of these populations is causing serious trouble. There's arsenic in the water supply. They've done a lot in recent years to try to correct this. A lot of times now you can tell which wells the water has arsenic, so that can be used for one purpose, but then another well will not have arsenic. But still, it's a major issue that, of course, has serious health implications. Large areas are just simply uninhabitable. So it's a small country to begin with. But again, down here where you see lots of rivers, that's all mangrove. There's no people. And then when these big rivers there, when it's the rainy season and the rivers get even bigger than how they look on the map, people who are living in these char areas, these islands in the middle of the river, they disappear. So people become isolated, they become blocked off during months at a time during the rainy season. What else is on there? So geographic challenges. Then we talk about demographic challenges. So if you exclude places like Hong Kong and Singapore, which are purely urban, Bangladesh is the most densely populated country in the world. And I'm here to tell you that as soon as you step out of the airport and you're in it immediately, it feels like the most densely populated country in the world. So imagine 170 million people, so roughly half the population of the United States. living in a geographic area the size of Iowa. Just try to imagine that for a minute. With large portions of the country being uninhabitable because of the mangroves and the salt water and the flooding and the rivers, and so it's palpable. You can't escape it. You know, the noise and the activity on the streets and the traffic. You cannot ignore it. Urbanization. So people come to cities for economic opportunities, and the more flooding you see in the rural areas, the more the salt water is contaminating the groundwater in the rural areas. The more people want to come to the cities for economic opportunities. Of course, as you can imagine, the challenges with that is where does everyone go, and what are they doing? The garment factories employ millions and millions of workers. I wish I could even estimate the number of rickshaw drivers in the city of Dhaka. These are these bicycle rickshaws. I guess I have a picture. But this is not an unusual scene but these rickshaws. This is the main mode of transportation for people that don't own vehicles. There are some buses, but rickshaws are easier and very cheap to get around. So urbanization, and then this demographic distribution. These are projections. But this is without even looking at precisely at the numbers, you can see how the shape of these distributions change pretty dramatically. From 2001, with the vast majority being under the age of 30, 2026 projected to see a more even distribution. But look at and then by 2051, almost uniform distribution with an increasing life expectancy, which generally is a good thing. But this affects lots of things. It affects employment, it affects health service delivery, it affects commerce and trading, and of course, how do you the population is not shrinking, I'll put it that way. I think the next slide, we'll get there eventually. Demographic challenges. So this is very typical. Here's one of the makeshift slum areas. So when people come to the city and they don't have resources to actually rent an apartment, they gravitate toward these slum areas. And this one is directly adjacent to one of the more prosperous and affluent parts of the city, just on the other side of this lake. And you can ride in a little rowboat. There's not a bridge, but you can ride in a rowboat from one side to the other, and you're in a completely different world. So these are, as you can see, these piles of trash. They're actually filling in the water with trash to create more land to build these makeshift homes on. These are made out of corrugated tin. They're made out of, you can see there's bamboo there, whatever they can find, PVC, just plastic, like banners that have been taken down. Whatever they can put together to make a home. These areas are not incorporated, they're not officially part of the city. So from time to time, the government will actually come in and just plow them all down, which is, of course, a tragedy because the people have nothing to begin with, and then their homes are taken away. So they rebuild as quickly as they can, but it's a very precarious and vulnerable situation to be in. They're also charging ridiculous amounts. So people who are living in the slum areas pay about 3 times the rate that I pay for electricity in my home. And it's because it's in a part of the town that's not incorporated, that's not officially regulated. So you have a landowner, officially or unofficially, you have a landowner, and this person charges rent, and they charge, so they're paying the electricity bill, and then they, of course, allocate a portion with their markup to the people living in the slum. So it's not it's not just a matter of having less resources. It's there's some structural factors here that mean that the deck is really stacked against you. So people work really hard. In spite of all this, people are so resourceful, very resilient, and they want their children to get out of there. They want their children to live in a more stable environment, to go to a school regularly, and to be more prosperous, of course. Just as a side note, this is a picture I took. I was sitting in a boat just kind of visiting this area. So this is an area that I work in as a volunteer. I'm on the board of a small nonprofit that was formed by 3 American women, and we deliver meals to school children in the slum areas to right now 6 different schools. We have 800 children, and we deliver something like 2,500 meals per week to the school children in the slums. And so this was important to me. The job I have now, I spend a lot of my time in meetings with government officials. And I go from my home and I get in my car and I have a driver and he takes me to my office, he takes me to my meetings, and then I come back home. So it's a far cry from the Peace Corps experience that I loved so much, where you're really connected to the community and you have a chance to see the real Dhaka. I wouldn't call the diplomatic zone the real Dhaka, but this, to see how real people are living, how the majority of people are living. So when they set up this nonprofit, I was so pleased because it gave me an opportunity to go and deliver the meals, meet some children, and understand the living situations, and feel more connected to the people in the city. Political challenges. So this is, in a lot of countries you have this. In Bangladesh, if one political party is unhappy about anything, they will call a strike and businesses will shut down and buses will not run. And then these go on for long enough, and of course it becomes very disruptive. There was a national election at the beginning of 2014, and there were several weeks where the strikes were nonstop. And so it's very disruptive to business and people trying to earn a living and just struggle to survive. And so, but it's still an accepted method of political expression. In India, they used to do that, but they outlawed it. And I hope that one of these days Bangladesh will come to the same conclusion that we just can't function like this. It's not helping, and it's disruptive, and it's not. Investors don't like to see that, and it's not good for the economy. It's not good for people. School children can't go to school. It's just people aren't getting the medical care they need. But still, they continue. So it kind of goes in spurts. Right now, so I've been in Bangladesh. This is my 4th year. Right now, one of the new things that we're facing is this idea of religious extremism. 90% Muslim country, traditionally very moderate, and the revolution in 1971 split off from Pakistan, and has been a more or less moderate country since then. The 2 main political parties go back and forth, but generally speaking, it's a secular state. There's religious freedom. They celebrate. There are Hindu holidays on the public holiday calendar. There's a Buddhist holiday on there, but this fundamentalist expression of Islam is starting to creep in. There are some political parties. So some of it is internal. And the sitting party is more or less moderate, and they've done their best to minimize the influence of the more conservative parties. But now what we're seeing is a backlash, because of course they feel marginalized and not, they don't have a fair chance to express their agenda. So we're seeing some backlash internally, and we're also seeing some evidence that there are external forces at work here. So recently, within the last 6 weeks or so, there have been a couple of murders of foreigners. There was a bombing of a religious procession. This year alone, 5 bloggers, so moderate to liberal bloggers, who the fundamentalists see as anti-Islam. Whether that's a fair assessment or not is moot. But 5 bloggers have been brutally murdered without any retribution. So ISIS is taking credit for some of this. That may or may not be the case. It may or may not be official. As many of you know, ISIS is very decentralized. It's not that there's necessarily an agenda and someone pulling the strings and a strict hierarchy of people planning what needs to happen. But several of these events that I just mentioned, ISIS is taking credit for. So it's an interesting time. It's a very tense time in Bangladesh. The government is responding because whether or not it's coming from inside or outside the country, the sitting government, it doesn't make them look great, and they want the stability. They want peace in their country, of course. So there's a lot more security forces around, a lot more blockades and checkpoints, curfews. The school where my son goes, the American International School of Dhaka, they're open until 9 p.m. so people can use the facilities, use the pool, the fitness center. They close at 6 p.m. now when it gets dark. So there's a lot of restrictions on movement because of this, and we'll see where it goes. I mean, I'm hoping that it's a temporary thing and it'll ease up, but it's hard to tell at this point which way it'll go. So, okay, so that's Bangladesh more generally, more broadly. I'll talk a little bit now about public health, because professionally, as a global public health person, Bangladesh is an amazing place to work. There's been a lot of successes historically. The government is generally supportive of both implementation and research projects. There's a very talented and educated workforce. It's a great place. You also, because of the population density, it's very easy if you're doing research to come up with the sample size that you need, right? It's easy. It's a captive audience. So life expectancy for a developing country, 70 years, that's remarkable. It really is. Vaccination coverage, so children receiving all 8 recommended or required vaccinations, 86%. That's amazing. Other countries would struggle to meet half of that. Total fertility rate. So this population density issue that we have is absolutely being addressed, and it's gone down substantially in 30 years. 6.3 to 2.3. Now, the thing that we're seeing now, though, is the most recent data. So in 2011, it was 2.3. They've released the preliminary data from the 2014 Demographic and Health Survey, and it's only gone down to 2.2, which, again, once you're that low, you're not going to see a huge change. But if Bangladesh is going to prosper, you have to slow down the growth rate. Right now, it's the population is still growing, and if it continues to grow at the current rate, it's not expected to reverse the trend until you hit like 2050 or 2060. So it's a high priority within the Ministry of Health and Family Welfare. You've got your Directorate of Health Services, which is everything except family planning, and you have a Directorate of Family Planning, which really focuses strongly on making contraceptives available, making sure the services are accessible and available, getting the information out there. And Bangladesh has done seen this success in the drop in fertility rate without using forceful measures like you've seen in China, for example, with the one-child law, which they've just changed. But other countries have been much more repressive in the ways that they choose to manage their population growth. Bangladesh has not been drastic in that way, and it's a huge achievement. It's a huge accomplishment. Child mortality from infectious disease has gone down substantially, to the point where right now, for children between the age of 1 and 5, the number one cause of mortality is actually drowning. And it's not that more children are drowning now than they used to, but it's that the rates of infectious disease have gone down quite a bit. And that's related to the next one. So, and that's because when they do get diarrhea, first of all, they know how to prevent it better than they did before. And when a child does come down with diarrhea, of course, it's very easy to get dehydrated, and that's where the mortality comes from. But 80% of children who recently had diarrhea were treated with this oral rehydration salts and recovered. And so that's this right here, the treatment with the oral rehydration salts and the drop in infectious disease, those are very much connected. Okay, so those are some of the successes, but of course there's still a lot of challenges. There always are. in a developing country. So newborn health. So even though the mortality in under 5s has gone down substantially, and Bangladesh has achieved its Millennium Development Goal of reducing child mortality, one of the few countries to actually achieve that. But you can see here, these numbers have gone down. They're still too high. That's still way too many children who are dying. But of the under 5s, 43 out of 53 are newborns, so within the first 30 days of their lives. So that's really where the emphasis is right now. You know, the older children, they're doing better. Their mortality rates have gone down quite a bit, but the newborn rates are still quite high. So looking at things like chlorhexidine for the cord care, looking at follow-up visits within 72 hours after delivery, because 75% of births take place at home. And most of them are not with a skilled attendant. They're attended by family members or someone who's, attended a lot of births, but not necessarily someone who's skilled and trained. So addressing the newborn mortality, child nutrition, 41% of children are stunted, which means they're too small for their height. Or no, that's backwards. They're too short for their age. 41%. It's a disgrace. I mean, how can children thrive when they're not getting the nutrition they need? So this is a very high priority. It's a number that has not budged in quite some time, and so it's receiving a lot of attention right now. Hope we can turn that around. And that starts with breastfeeding. It starts with and then the introduction of complementary foods. If you start out right, it's easier to continue right. And it's not necessarily that they're not getting the calories, but the nutrients that they need. Or if they have diarrhea, they're losing those nutrients. So it's connected, but this is a number that needs to go down. Age at marriage. Here's another number. We've seen the rise in immunization, the drop in fertility rate. This is a number that has not changed very much in decades. The average age for girls is 15 and a half, average. And you can imagine, so if they're married, they're not going to school, they tend to get pregnant very quickly. They're absorbed into the households of their in-laws, and they're low on the totem pole, so they get bossed around quite a bit. And then when they're that young, what kind of voice do they have? What kind of choice do they have? So this is another really important thing for Bangladesh as a public health challenge. It's not, even though it's not directly a health challenge, it's age of marriage, but it affects teenage pregnancy, it affects maternal mortality, it affects anemia, lots of different ways. And of course, if you ask me, gender equity is a big part of public health, even if it's not technically a health issue. Okay, continued emphasis needed on family planning. Like I mentioned before, you can't just expect that it will continue to decline on its own. So to see further decline and to stabilize that population so it goes down to replacement rates and stays at replacement rates needs a strong continued emphasis. You can't just glide on past success and expect to see that maintained. Global health security. So this is kind of the buzzword, the global health security that has emerged from the Ebola crisis from last year in West Africa. Really a recognition that it was a wake-up call, and this could happen anywhere, anytime. It could be Ebola, it could be something we haven't even dreamed up yet. And so part of the reason Ebola spread as quickly as it did was because the health systems were not already in place, that the system was weak to begin with, and they were not able to respond as quickly. Eventually they did, with a huge input of resources, and I think 2 out of the 3 countries are officially Ebola free now. But it was a wake-up call, and this emerging pandemic threats were more and more globalized, and it's easy for diseases to travel. So this is an emphasis. It'll come through the CDC. It's being funded through the CDC. They're getting a lot of funding for this. USAID will be involved somehow, but I think CDC is really in the driver's seat here. But this is, you'll hear about this in the next few years. Preparedness, essentially. Access to and quality of care. There are lots of clinics and buildings and structures in place. They're not fully staffed. Just because they're there doesn't mean the service is available. Doesn't mean it's available when you need it. Doesn't mean the quality is good. So there's a long way to go in terms of quality of service delivery. And they're moving towards universal health coverage. This will take many years, but this is a priority that the government is talking about now. And then non-communicable diseases. As I mentioned earlier, for children, child mortality, the rate of infectious disease has gone down quite a bit, and that's true for the whole population. So I know that it's really small. So the red, let's do this. The blue here, that's the infectious disease, and then the red bars immediately above that, those are the non-communicable diseases. So this is heart disease, this is diabetes, this is cancer, things like this. And so you can see from 1986, this goes up to 2006, but you can see how it's shifting, which is the same way we saw it in this country and in any other developed country. You see that shift. Maybe it doesn't happen as fast as this. Maybe it takes more time in different countries, but we're seeing a shift, and it's a whole different approach, of course, when you're working with what they're calling lifestyle diseases, which is I would argue with that term, but it's an entirely different approach to public health. Okay, we're doing good on time. So this is Bangladesh generally, public health in Bangladesh generally, and then so our particular projects, we're capacity strengthening and technical assistance primarily for the Ministry of Health and Family Welfare. And that just means that we're not doing anything directly. We work on health communication, behavior change, communication for social change, but we want, our purpose is that the government is able to do this better and is not dependent on donor funds or international non-governmental organizations to come in and do this work in the long term, but that the local systems are in place, that the local government is able to do this in a more effective and strategic way that's based on data, that's based on what the audience needs and not what the experts think is needed. And that's what we do. So really there's two ways. So really it's this capacity strengthening, and then we have this community of practice, which just means coordination is a challenge when you talk about behavior change communication activities. And these are broad-based community or mass media campaigns to provide information, to change behaviors. If it's eating healthier foods, if it's using a modern contraceptive method, whatever it may be, if it's newborn health, if it's complementary feeding, we want to see these behaviors improve. But there's a lot of coordination. There's a lack of coordination. A lot of people doing a lot of things, whether it's the government, non-government, the corporate sector, and the factories, things like that. And so we have a forum where we meet regularly and we network, we learn from each other, and we share. And we try to improve that coordination around behavior change. This is just I don't know if that's legible, but this is how we think about our capacity strengthening work that we do with the Ministry of Health and Family Welfare. We realized very early on that if we just focus here on the individual level and improving the knowledge and the skills of the people who work in the Ministry of Health and Family Welfare, well, those people change. So we started out doing some trainings and some workshops, and then we saw a lot of turnover. People are transferred, they retire, they get promoted, and what's left? You had your workshop 2 years ago, and now what's left? Not much. So we really focus our efforts on organizational processes and tools, and then at this system level, this coordination and integration. And like I said before, you've got your health and you've got your family planning, and they're totally separate. But that's not how a household thinks. If you're a family living anywhere in Bangladesh, you're not making a distinction in your head between my family planning needs and my nutrition needs and my children's immunization. It's all your family's welfare. You want your family to be healthy, to go to school, to work, to earn a living, to be prosperous. So these distinctions between the family planning and nutrition and health are quite artificial when you think from a family's perspective, from a household's perspective. So we talk about coordination of activities and then the integration of the information, because that's what people need, integrated information and services to keep their families healthy. Processes and tools, these are something, as simple as a digital archive that wasn't there before in these government units. And it seems so obvious, and it's interesting to me that they're saying, oh, this is such an innovative thing you're doing. And no, it's a server. You create something and you keep a record of it. You document it so that people know what you've done, and if you want to do it again later, you can start somewhere. But this is new. These digital archives in these three units that we work with, these three governmental organizations. Tools around monitoring, around following a process for planning and designing behavior change interventions, and not just, well, this sounds good, or I had a great idea, but following a process where the audience is very much involved in the planning and the implementation and the monitoring. And also changing this mindset of behavior change communication as just disseminating messages. Just get the information out there, and then everything will be fine. Well, if it was that easy, no one would smoke, everyone would wear a seatbelt. It's not that easy. The point being, but there's still this old school mindset of we have to disseminate the information, we have to get the messages out there, and that's not communication. That's top down directive, and it's not very effective. So. Whatever we can do to encourage two-way communication, whether it's between the audience and the planners, and to feed that data, that feedback loop, put that in place. Or what can we do to stimulate dialogue and discussion within the communities that we're working in? So it's not just that they're hearing something from the experts, but they're talking amongst themselves. They're problem solving. They're looking for solutions. They're talking about things they hadn't talked about before that may have been private. But once you bring them out into the open, now you can bring a solution. Now you can sort of demystify some of the things that like family planning, for example. The main, the real forceful interventions really happened during the 90s, and prior to that it was considered it's a very private thing. This is not something you talk about with anybody, out even within your family. But part of the reason it was successful is because it's become something that's okay, it's acceptable, it's socially acceptable to talk about family planning. How many children would you like to have? And that's a huge achievement. And you can't have the service uptake if people are shy or embarrassed to even talk about it. And then at the system level, so again, the coordination, this working group that we have, this community of practice, there's a problem with the distribution of the materials. We knew that things were being produced at the national level, but when you go out to the grassroots level, you're not seeing what was produced. The government, they said, yes, we printed 500,000 posters. We've ticked our box. We've done what we were supposed to do. But where are the posters? Probably, sitting in a box, sitting in a storage room somewhere. Or, they create these flip charts for the field workers, but the field workers say, what flip charts? What are you talking about? So there's some cracks in that system. So we did a study to see how to improve that system so that the materials are actually reaching their intended audience. And this was kind of a fun thing. I'll just share one. This is it's a toolkit. It's an online toolkit. This is just a screenshot, so I won't go into it. But we created this for the field workers. The government has 42,000 field workers who are out in communities, going door to door, talking to families, doing their counseling. Sometimes they sit at the clinics. Sometimes they go to the schools. But their job is to be in the communities providing counseling. Well, you've got your health assistants who do the health, and you've got your family welfare assistants that do the family planning. It's totally separate. And they don't get much training. So at the beginning when they're hired, they receive some kind of training, but they don't get any sort of refresher. And a lot of their information is outdated, hadn't kept up with current government guidelines and policies. And they told us, they said, look, people ask us questions and we give them an answer, but we're not sure that it's the right answer. And so what we did, we compiled different brochures and posters and television commercials and radio spots, different things that had already been developed, so we didn't make anything new, but we compiled them into this online toolkit. And we gave them netbooks, computers, so a small version of a laptop, totally offline. And then they carried their netbooks around and did their counseling. So we didn't add anything new. We gave them a tool to help them improve what they were supposed to be doing. The field workers loved it. The clients loved it. Because it's colorful. It's intuitive. So this one on the far left is health, family planning in the middle, and nutrition over there. The pictures, we pre-tested this. Do you want icons? Do you want just a simple figure? But they wanted the colorful pictures of actual human beings. And so when you go in if you click on family planning, then you have a series of categories: long-acting methods, short-term methods, permanent methods, and things. So it's very intuitive. You just have to click on the icon, and then you get a list of supportive, counseling aids, I would say. Some are printed, some are audiovisual, but it's very intuitive to try to navigate this. When we designed it, we were presuming that the field worker had never even touched a computer before. Right? So that was our thinking. And of course, some of them had some good computer skills, but we wanted to make sure that it was useful for kind of the least common denominator, so that we were sure it would be useful and appropriate. The counseling sessions took more time because people were asking more questions, but it means also that their needs were being met, right? So instead of a health person saying, oh, I don't know anything about family planning, someone else will come to talk to you about that. She could actually go in there, so start clicking around in the family planning piece, look for the answer to the question that her client had, and provide that information. That's what the client wants. That's what the client needs. And so it was successful. We did this on a pilot basis a couple years ago, and we're in the process now of scaling it up nationwide. We've converted it to an Android app, so I have it on my smartphone. And the government is in the process. They've purchased tablets for about half of the field workers so far, and we're constantly advocating that they purchase tablets for all of them. And that's not just for this toolkit, but also to collect data, to keep client records of which households you go to have unique ID numbers for each of the families and the people in the families, so you know the ages, the marriages, the births. You have all that information in that tablet. Right now, they carry around these giant ledgers of paper, and they're writing in paper. So the Bangladesh is investing in technology and moving in that direction. So it's good to see, and we're there trying to help as much as we can. Just 2 more minutes. One of the exciting things that our project is doing right now, is we're involved in a lot of policy and advocacy work. So the Ministry of Health and Family Welfare works they have this sector-wide approach, which again tries to integrate the health, population, and nutrition. And these sector plans last for 5 years. Well, we're at a moment where the one 5-year plan is about to finish in June of 2016. So the planning and the discussions for the next 5-year plan are very much underway, and so we're involved in that, trying to raise the profile of behavior change communication. The Ministry of Health tends to be very clinical. A lot of doctors there who are not necessarily convinced that a public health prevention approach is appropriate or effective. So we're here to raise the profile of behavior change communication and to really spell out what does it look like if it's done well. What is required for it to be done well? What are the theories you need to be thinking about? What are the processes to follow? What are the guiding principles? So we're actually drafting a comprehensive national strategy for social and behavior change communication that hasn't existed before. Until now, the communication strategies have been at the implementation level, so this is more of a guiding document. So for me, this is fun. To be working at this level, because it'll influence the next 5-year plan, and that's part of the role of our project. But this is the real reason that I'm in Bangladesh. This is the real reason that I'm in public health. You know, we're not here just to create policies and strategies and strengthen capacity for the sake of strengthened capacity. We're here because we want to see healthier children. We want to see healthier families. We want to see a prosperous Bangladesh where people have opportunities to thrive and succeed. And these kids go to school and they're a healthy size for their age. And they grow up and they finish school before they get married and start having children. This is why we do what we do. Thank you.
This is an interesting start. How do you measure the effectiveness of your interventions and programs?
Great question. And with when our project, our mandate is capacity strengthening, what does that look like? And how do you measure that? How do you quantify that? How do you isolate that and pinpoint it? It's very difficult. We see a lot of qualitative evidence of changes and improvements, but really we will be satisfied when we see the government truly owning these tools that we've developed with them. If they truly institutionalizing these tools and these processes, these routines at the organizational level, and continuing these coordination mechanisms at the national level. So for example, this toolkit that we developed with the government very closely, so it's not that we did something and we're trying to say, here you go, this is for you. But we've worked on it together with them. So now we're working with them to strategize, okay, well, how do we get this to the field workers? How do we make sure that all of the community clinics have access to this? So we will be very happy if after our project finishes, and our funding will go through September of next year only, if the government continues to think of that toolkit as belonging to them. And that they host it on their servers, they update it annually, they make sure that it's getting to the people who can use it, that they're trained on how to use it. That will be successful for us. More generally speaking, with communication interventions and social and behavior change communication, so communication can solve. You can use communication to address certain things, but not everything. And because there's a lot more factors. So let me give an example. So if you want to have an intervention where you want to encourage pregnant women to go for their prenatal checkups, the recommendation is they go for 4. In Bangladesh, usually they'll go to 1, some will go to 2, very few make it all the way to 4. So if you want to encourage pregnant women to go to prenatal visits, you can have an intervention and explain why this is important and direct them to the services and accompany them if necessary. So you may, from the beginning of your intervention to the end, see a change in the number of prenatal visits that pregnant women attend. And so that would be a success, if you can show a change in those numbers. Now, can you claim to have affected maternal mortality with that one intervention, right? So, but because maternal mortality, there's so much more involved. It's, the health service delivery, the human resources. I mean, it's a much bigger thing that has a lot more than just, has she gone for her 4 prenatal checkups? So, so for communication, you have to set your indicators in a way that you're measuring something that you can actually achieve with communication, right? It'd be very difficult to try to, it's purely a communication intervention for maternal mortality. But you could increase the rate of prenatal visits. You could do that.
Okay, a more personal question that might interest our students. How did you acquire or develop your media and communication skills which you use in your current job? Degree program, learning by doing, or both?
The short answer is learning by doing. So I have a liberal arts degree, I worked for 5 years in the publishing industry, where I learned graphic design, and I became an art director for magazines for the advertising industry, trade magazines. And then in Tanzania, we were publishing magazines, which is a really good connection with my previous experience in Chicago and the health education in Madagascar. But television was a brand new. Any other sort of media production I've had to learn while I'm doing it, which is part of the fun, and it helps when you have good colleagues that can teach you what you need to learn.
Okay, back to Bangladesh. Is extreme Islam deeply, perhaps violently, opposed to family planning and to health projects, nutritional projects?
Interesting. So if there are, there's I could talk about this for a couple of hours, but I'll keep it short, I promise. Because if you look at family planning rates, so in Bangladesh, the contraceptive prevalence rate, so the rate of people who are actually using any method of contraception is really quite high. It's like 72%. Modern contraception is like 61%. That's very high. But if you look at the method mix, most people are using short-term methods. And when you get married when you're 15, you complete your family size by the time you're 20, you've got a lot of years where you're still of reproductive age that you have to manage your fertility. But the method mix is very much skewed towards short-term methods, which doesn't make sense, because IUDs are available, the implants are available, permanent methods are there, but people haven't really taken those up. And so the opposition to family planning is not broadly against family planning. In Bangladesh, there is some people who so for example, if you have a long-term method, you might see some spotting in between your menstrual cycle, and then you're not allowed to pray. If it's Ramadan, you can't fast on that day, so you have to do it. So it's disruptive to religious practice, right? There's also a belief that the Quran says if when you die, you're not supposed to have any kind of foreign object in your body, and an IUD, people would consider that a foreign object. There's also a lot of myths and misconceptions about, the Norplant, or the implant, floating and traveling through the body. So it's not necessarily a broad objection to family planning. In other, mostly Muslim countries, you see higher rates of IUDs and implants. So there's something else going on, and we're still trying to figure that out. And there's a balance between service delivery, service provision, and having the information. And dealing with the fear, there's a lot of fear. This is your body. You're talking about. A lot of things could go wrong, and there's a lot of things to be afraid of. So to address that, it's been a challenge, and Bangladesh has been making that effort, but still hasn't seen much change. Some of it's religious, but not all of it.
And a not unrelated question, the age of marriage, is the pressure on families to marry off daughters as soon as possible to relieve pressure on younger children?
Okay, this is another one I would love to talk about for an hour. Yes, that's part of it. That's part of it. So it's even though the bride's family pays the dowry, it's seen as that there is an economic incentive, because then she becomes the property. She's absorbed into her in-laws' family. There's also a sense this idea of marriage as a protective factor. Most marriages are still arranged by the families, and so the longer a girl is unmarried, she is susceptible to having a boyfriend, or deciding that she has a crush on someone, or eloping, or even walking back and forth to school. The young girls face a lot of sexual harassment, which, even if all she's doing is going back and forth to school, can be shameful for the family. If she gets involved in some kind of a situation where there's a rumor that started, or so marrying her is one. It's seen as a protective force, which of course again is very counterintuitive because of all the negative impacts on that young girl's life when she's married at a young age. But there's a big sense of that too, of as long as she's unmarried, she could do something or something could happen to her that may bring shame on the family. And if she is married, first of all, now she belongs to that family, and if she does something wrong, it's shameful for them, not for me. But there's economic things, there's also just a sense of this is how I did it. This is how we've always done it. And so it's a really tough cycle to break.
Okay, and I've left the toughest question to last. How has US intervention in Pakistan affected or influenced Bangladesh?
Oh. This may be beyond my wheelhouse. The short answer is I don't know. I don't know. Is it recent or historically? Who asked this question? Yeah. Because so there's the book that's been published in the last couple of years. It's called The Blood Telegram, that actually talks about the U.S. involvement in the revolution of 1971, and that is the next book that my book club will be reading. It's on my nightstand right next to my bed, but I haven't actually read it yet. But the U.S. was involved very much so behind the scenes during the revolution. This was in 1971. When the split between East and West Pakistan happened, but I'm afraid I don't know the details. I haven't read the book yet.
Thank you. We'll conclude our program now. So on behalf of the Iowa City Foreign Relations Council, I want to give a big thank you to Rebecca for her presentation. I also want to thank our sponsors, University of Iowa International Programs, the University of Iowa Honors Program, and the Stanley UI Foundation Support Organization. We thank again our today's financial sponsors, Dick and Joyce Somerville and Jane McEwen. Rebecca, as a token of our appreciation, we're going to present you with a coveted Iowa City Foreign Relations Council mug, which is here. We conclude our program. Thank you for coming.